Now we'll talk about the causes of malnutrition with liver disease. There are a number of factors that contribute to malnutrition, and one of these is reduced nutritional intake. So patients can experience a reduced appetite. This can be because of nausea and vomiting, which can be caused by inflammation and impaired gastric motility, or even just being unwell, for example, having high bilirubin. Early satiety occurs in patients who have ascites, and this is because the stomach has a reduced capacity to hold food. An altered sense of taste and smell often also occurs, and this can be worsened by malnutrition, for example, by micronutrient deficiencies such as zinc. Dietary restrictions are also common, which can lead to reduced intake. So patients are advised to follow a no added salt diet if they have ascites, and fluid is sometimes restricted for people who have bad edema or low sodium levels. And sometimes we do still see protein being restricted to treat hepatic encephalopathy, which we now know is not appropriate because the body will just break down muscle in this case, and that worsens the encephalopathy and worsens sarcopenia. Hospital admissions are common, and this then causes a change in food. Often people dislike hospital food, and nil by mouth for procedures is common, reducing intake overall. For people with alcohol-related liver disease, alcohol intake contributes to malnutrition because patients replace food with alcohol, and this provides them with calories but not with micronutrients or protein. Another factor contributing to malnutrition is malabsorption and losses of nutrition. Fat malabsorption is common, and this can be due to impaired production of bile, particularly in patients with PBC and PSC. When this is experienced, deficiency of fat-soluble vitamins can occur as well. Pancreatitis and pancreatic enzyme insufficiency is also common in patients with alcohol-related liver disease. And the prevalence of small intestinal bacterial overgrowth in patients with decompensated cirrhosis is 51%, and in compensated cirrhosis it's 31%, and that's compared to 11% in controls without cirrhosis. So small intestinal bacterial overgrowth can give people symptoms, so things like nausea, but it also can contribute to the malabsorption of fat. When people have paracentesis, there's a net loss of protein of about 6 grams for every litre of ascites drained, and that's accounting for the protein that's replaced with human albumin solution. And then things like medications can have an impact as well. So lactulose, diuretics, rifaximin and cholestyramine, they can all contribute to malabsorption of nutrients. So altered protein, fat and carbohydrate metabolism can also occur in patients with liver cirrhosis, and this can contribute to malnutrition. Branched chain amino acids are lower and aromatic amino acids are higher compared to healthy controls, and observational research suggests this is due to branched chain amino acids being used for ammonia detoxification and as a substrate for energy. And this is relevant because branched chain amino acids are needed for protein synthesis in the body, so building muscles. Insulin resistance and high blood glucose is common in patients with liver cirrhosis. And due to reduced liver glycogen, there's an accelerated state of starvation where an overnight fast in someone with cirrhosis is the same as a 72-hour fast in a healthy individual. This then leads to the use of protein and fat for gluconeogenesis and the production of ketones for energy. For some people with liver disease, there's increased energy expenditure. Researchers found that between 15 and 30% of people with liver cirrhosis have increased resting energy expenditure. However, we also have to balance this with lower levels of physical activity, and therefore the energy expended due to physical activity is lower.